Thank you, Atul. And just wanted to say again, thank you to Finn, particularly Noel and Christine, for inviting me today. And so this is the topic I've been given. And Jerry brought up a very important point earlier on in the day about pain and subjective measurements and whether we could then use that for monitoring treatment or should be looking at objective treatment measures. Now, of course, children with Fabry disease, I've been working in this area for nearly 10 years or a little bit more than that. And the main area of interest, The main area of interest, the main area of interest really for me is to look at the natural history and to see whether we can identify early but subtle markers of disease severity in children. So that's been what we've been doing for a very long time. Just to continue with the theme that everybody else said, where they come from, that's where I come from. So I think I don't need to say any more than this. So the Willig Biochemical Genetics Unit is in Manchester. And I'd first of all like to say that this is the first meeting I've been to after our beloved Professor Raid passed away. So I'd like to actually, this is a tribute to him. So I just want to say thank you to him. He's been my mentor for all my career and has nurtured me right through in my lysosomal storage disorders career. So Ed, this is for you. And by the way, he doesn't support Manchester United. He's probably now really annoyed with me. He supports Newcastle United, and I support Arsenal. So so I think the first sentence really is nearly 2/3 of children, many of you who are patients, will remember that pain for you as acroparesthesia was probably present before you were even 10, but probably not recognized and called whatever else it was. So we now know that nearly 2/3 of males with Fabry disease will present with acroparesthesia within the first decade of life. So that's a fact that we've now well established. I'm not going to show any details today, but what we've also done is we've looked at the back of the eye. So I know that we look at the cornea verticillata, which is quite commonly looked at in adults and children with Fabry, but we've looked at the retinal vessels. So really, I suppose, as a surrogate marker to how you can look at small vessel disease within the brain. And this was published in 2010 from my own unit. Louise Allen is our ophthalmologist. And we looked at 22 children, and what we found, if they had mutations that had loss of function, so it could be a missense mutation, it could be a nonsense mutation, but if it was a missense mutation with a loss of function, then clearly they had onset of retinal vessel tortuosity before the age of 10, very young. And then we saw that progress as they got older, and then we used that as an indication for treatment. We've also, Anna Rose Kalman, who's from Germany, and our own team, we've also correlated early onset tinnitus with disease severity. Again, I'm very happy to talk about all these things later, but for today's talk, that's just a brief. So there are some objective measures we can use now for looking at children with Fabry. You've already seen this slide very many times, and the reason I put this up is people talk about proteinuria, and I'm going to talk a little bit about microalbuminuria. I suppose it's one of the how would you call it, Sandro? It's one of the early renal indicators of the early sort of easy test that you could do to assess for proteinuria. So proteinuria will have lots of proteins in it, so we look just at microalbumin. But Dominique Germain and everybody else have shown that if you had a lot of protein in the urine, then you have a reduction in GFR. So this is actually a slide that Michael West gave me from his paper, showing that if you didn't treat patients, then you have significant decline in glomerular filtration rate, and then depending upon whether they had a lot of protein in the urine or if they had less protein, as Sandro mentioned, then you can to some degree preserve the glomerular filtration rate. But in children, quite often, glomerular filtration rate is going to be normal. Cardiomyopathy is virtually, you don't see that very often. We don't see stroke. So these are all not going to be helpful for us. So we need to look at some other way of how we can monitor our children. So I'm going to concentrate on the kidneys and the heart today. And for the kidneys, my very good friend Camilla Tondel has done some great work on children with Fabry disease. So the first paper she published in 2008, 2008 was on renal biopsy findings in 9 children. And the average age the age group was between the ages of 7 and 18. And she had 7 males and 2 females. And she did biopsies on them. This is before treatment. And she found that Sandra mentioned all these cells within the kidney, so the glomerular, the tubulointerstitial and vascular compartments, all of them had storage. So she showed that they were all abnormal. She also showed very early on that there were podocyte inclusions. Sandra has already mentioned the importance of podocytes and how they regulate very many proteins and also filtration. For me, the most important message in that paper was not the renal biopsy per se, but 85%, 6 out of the 7 boys, and one of the small numbers, so 50%, but it's one of the girls had microalbuminuria at the time of biopsy. So to me, what I tell pediatricians is that you don't need to necessarily do invasive tests all the time in these children, but if you can very carefully monitor microalbuminuria, then I think you can pick it up early. I take your point, Jerry, about Mike Moore's talk, that sometimes you can get renal disease involvement even before. Of course we can. If you look at placenta, you've got GB3 accumulation in placenta. The point we need to do is to be realistic. When is the point where you think would be most likely we need to be starting treatment if you want to make a difference? So are we going to start at birth? I don't think we're there yet. So for me, that is not necessarily the argument. For me, it would be, what do you want to find? And this is, in fact, Behzad, you talked about Najafia, and Behzad is a good friend of mine, and he looked at, again, Sandra mentioned the food process within the podocytes, and he showed a clear correlation that as you had an increase in that food process then you had an increase in albumin. Very similarly, he had a correlation between age, so as the children got older, then you had the food process was getting wider. And he showed the same thing with males and females. So again, the same story. Now this is, Sandra mentioned, or I can't remember, somebody mentioned that podocyte clearance is dose dependent. I want to, Jerry, you mentioned earlier on today, we need to choose important studies and see whether they're going to be informative. I think when you also look at studies, you need to be really careful in reading the whole document, making sure that you actually understand what is actually being said. So if you just look at the abstract, it will say podocyte clearance is dose dependent. But in fact, I think for me the message was all these children had early onset microalbuminuria that you should have identified and perhaps treated even earlier than they were. So this was the study that was very recently published by Camilla again. So she looked at boys with treatment, she says agalsidase because she's got beta and alpha in this, 7 to 33 years. And she looked at 5 years of treatment. So she looked at, so there was a long period, so 65 months, and whichever treatment they were, there was a total clearance of GB3 or GL3 accumulation within the glomerular endothelial and mesangial cells. But she also showed that there was a significant correlation between podocyte inclusion clearance and the change in albumin creatinine ratios in 10 out of the 12 patients. So that was quite important. So there was a correlation. So the key finding, just to summarize in what she did, she showed 3 patients in that 12 that she had. One was 16, one was 17, and the other was 33. They were all on agalsidase alpha for up to 2 to 3 years prior to baseline biopsies. They all had very severe mutations, so they had truncating mutations, so the protein was not being made. One patient, so one of the 3, was increased to 0.4 of Replagal with a clearance of podocyte GL3 inclusions, and then she switched to Fabrazyme and showed that there was further clearance. 2 of the 3 were on increased dose of Replagal, so they were on 0.4 with no significant clearance at 5 years. But if you look at the paper on the whole, after 5 years, 7 of the patients, so there were 2 who were on Replagal at the standard dose, 2 on 0.4, and there was 1 patient on 1 milligram. All of them had little or no podocyte clearance. So I'm not entirely clear. We can be 100% sure from this documentation that podocyte clearance was definitely related to an increase in the enzyme. I think there are other things that are happening which I don't think we know at the moment. The most important thing for me was this. She had a 7-year-old boy, but this boy had a missense mutation, so it wasn't a very severe mutation. It wasn't loss of function, if I could remember. had almost complete clearance of podocyte inclusion, so the score of 4s, they scored the podocyte inclusion from 0 to 4, 4 being worst, was most severe. And so the score of 4 at baseline, and then it was down almost virtually non-existent at 5 years. But interestingly, at the age of 7, he had raised albumin creatinine and protein creatinine ratio, and he also had raised plasma and urinary GL3, as you would expect. So to me, this is really a very important biomarker in children, that if you identify, so what I recommend normally for these patients is 3 consecutive urine samples, first thing in the morning, so you take 3 and then you take the median. It's really important, it's quite easy to do. Then you can find these patients. So to me, that is really important. So just moving on to the heart.
Can I ask a question?
Yeah, sure.
So in the results that you just showed, so I guess the question remains is, one of the many questions, is the lack of reduction in podocyte clearance at a later age, does that contribute to the possibility that the earlier you treat, the better chance of clearance, or does it say that after a certain time, ERT is just not going to be effective?
Well, I think I agree with both, actually. So I think for me, the most important message there was the 7-year-old who had renal biopsies. There are 2 take-home messages there for me. One is, for me, I don't think you need to always do renal biopsies to make a diagnosis of renal disease in children. So a 7-year-old, I don't necessarily would agree that you need to biopsy all of them. But if you do see microalbuminuria, you know that that child's kidney function is probably going to decline quite quickly. So for me, that's an early clinical marker. So there are both questions. And to me, no doubt, if you start early, then regardless of the dose, I do think these children are going to do better.
I took that as more of the point of the paper anyway, that maybe even microalbuminuria is better, but even at a proteinuria at a very early age is evidence of disease progression, which may warrant treatment. Not necessarily that they need to be.
I think Mike Moore's view is always that microalbuminuria perhaps is not as sensitive, but for me, from what I have seen in my personal experience, we use that. So there are 2. So that's it. So you heard a lot about cardiac changes in adults today, and I thought it was a brilliant talk. And it's a shame Peter's not here. But I just thought I needed to talk a little bit of what we are finding now in changes in ECGs and in echoes, that if you just do a routine 2D echo, you're going to almost certainly miss. So this is just basically a little bit about what the ECG, I'm sure all of you know what the ECG is. So it's, this is a trace, a heart trace, and it's as the electrical impulse flows through the heart, a process of depolarization and repolarization occurs with every beat, and that's what you're actually, so depolarization means it's the active state, and the repolarization is the resting state. And what the 12-lead ECG does is it captures very many parts of it, and I won't go through in detail, but depending upon whether there's depolarization or whether there's repolarization, you can measure each segment. The only thing to say is that if an adult cardiologist sees an ECG in a child, he's going to think they're all very abnormal because they're very, very different, especially in the newborn period. The ECGs, because the heart rate is almost like 150 in a neonate, and that's normal, but 150 in an adult is very, very abnormal. So it's really important that you know that there are differences. And the size of the ventricle also changes as the infant grows. And there's always a right ventricular predominance. So they will have right ventricular hypertrophy when they're neonates or even when they're a young child. And as they get older, that will change. So again, these are very important differences that we need to recognize. And I've just put this in to show that this is really important that you look at the difference that, all these measurements that we take at birth, at 6 months, 1 year, 5 years, and 10 years will be different. So for children, it always has to be age dependent. And if you remember today, I just put this in because Peter showed you the T waves in these leads and said that that's myocardial ischemia. This is normal in children until the age of about 8 years. It's called juvenile T-wave pattern. So it's really important to make sure that people who look at ECGs are familiar with what we're looking for. Of course, T-wave abnormalities can be abnormal later on, and we found that in one of our studies, which I'm going to present. But it's just a point to say that we can look at. In fact, this is what we know so far from Christoph Kampmann. He's shown, we talked about valve disease today. So mild valve disease is very common in children, but doesn't cause any problems, so we don't really worry about it. Left ventricular hypertrophy can be present in older children. We don't routinely see it in younger children, but we do see it in adolescents. However, what we did do, Brazella and ourselves looked at very young children under the age of 7, and the left ventricular mass was, you remember I told you about the age-appropriate, you need to compare. So when we looked at age-appropriate charts for left ventricular mass, many of these children actually they were over the 75th percentile, so they were right on the top of the normal range. So it was an interesting finding for us because you needed to follow them up because those were the ones who were then probably going to develop left ventricular hypertrophy. But if you looked at a snapshot and you just looked at 75%, you just say, well, that's fine. What we really need to do is check them every year to see whether there's progression. This is something that we haven't been able to reproduce. Christoph Kampmann showed that there's a reduced heart rate variability, but we've looked at lots of children. At the moment, we haven't found a difference, so I think we still need to wait to see for further information. Okay, so for this study, so this was just published this month. So Stefan Havranek is from the Czech Republic in Prague with Professor Aleš Linhart. He came up to our center whilst I was in Cambridge, and basically we gave him, so we had 22 children, of which half of them were boys, 5 of them were an enzyme replacement. We had ECG, in fact we had nearly 3 or 4 years of ECGs and echoes. So we anonymized everything, locked him up in a room literally, well, not quite locked it, but put him in a room, didn't give him any other details apart from which year it was, and we asked him to analyze the data. And we found some very interesting information. And I have to say, things that our own cardiologist had missed, we picked up, because he did it anonymously, independently looking at things. And if you remember, I told you, so the PR interval is the first stage of repolarization. I talked to you about repolarization and depolarization. So the first stage of depolarization is when you have the impulse from the atrioventricular node gets into the heart through the right ventricle. So in children, PR interval is very short, and then it prolongs. Whereas if you look at in adults, that's quite abnormal, isn't it? If you have a prolonged PR interval, it's very short. I've only got 3 slides. Thank you. So what we did is we looked at the classical mutations that Professor Jaman mentioned, and we looked at the cardiac variant. And what we found is that what you would normally expect is this. As children get older, your PR interval should prolong. Whereas what happened in the classic mutation, it just simply didn't occur. So this is a very early sign or objective measure to say that something is not right with the heart. So this is probably when we should be treating, when the cardiomyocytes are probably still working but not working great. So this is probably when we need to be treating. But also we looked at, the paper actually talks about girls and boys, and there wasn't too much of a difference, so I'm going to just concentrate on the mutations for today. What we did is we looked at 3 boys, and we looked at the total number of children, the proportion of patients, sorry about that. Then we looked at those who had the classic mutation, and then we looked at the cardiac variant. We looked at 1 year, and we looked at 2 years. And the blue bar just basically shows that they have developed left ventricular hypertrophy. These were adolescents, so these were over the age of 10 but under the age of 18. But as you can see, 3 children, despite being on enzyme, so these children were actually, I meant to say, were on enzyme replacement therapy, despite having enzyme replacement therapy, have actually progressed. So, Karen.
How did you determine in the case of the kids that they were cardiac variant by
mutation analysis? Mutation analysis. It's the mutation, N215S.
So it was an identified cardiac variant mutation.
That's correct. And with a family history of N215S, whose family presented at whatever age, 30, 40, 50. So, oh yes, all our patients were mutation, all of them had mutation analysis.
How many patients are there? How many patients?
So this was all 22 to put together, but this was only the 3 patients.
With N2.
So this was the classical, yeah? And this is the N215S. Yeah, and so what we found is those 3 boys who had the N215S, the classical mutations progressed. So this is the total, yeah? So this is the total, this is just the classical mutations, and this is the N215S. But in that cohort, we didn't see a progression. But we also found that the left ventricular mass was significantly up in many of the girls. So I just want to conclude that these are early days. There are a small number of patients, although they are from one center, and we have carefully monitored them. But I think we do have a handle with some objective measures. So microalbuminuria, I think, is a very good early, non-invasive marker of renal disease progression. Early ERT, I think, below the age of 10 years, could reverse or even prevent the accumulation of podocyte inclusions, and I think that is a very important message. Renal biopsy, I think there is a role for it, for sure. There is a role in children, but I do not think that it is part of routine clinical care. I'm not convinced it is quite yet. I think there are other markers we could use. I think for pediatricians, this is really important. They should be looking at numbers, but doing it year on year and making sure that they're not just saying it's within the normal limit, but looking at whether it is actually prolonging or is it getting worse. That's the key message for me, because they'll all be normal. And I think that's why people say children don't have any problems. That's because we're looking at the wrong measures. We're looking how we're doing it is wrong at the moment. And I'll put my hand up too. 10 years ago, that's what I did. And 3 boys, they had the classical mutation. I think we need to understand a little bit more about these who progressed. And maybe even when we looked at it, maybe it was too late, because they had changes in their ECGs well before we started ERT, but we had missed them. So I'll put out my hand, because now we know more. We monitor them much more carefully. And we couldn't see any significant arrhythmias, which are very serious in the adults, but we haven't seen it. So I just want to finally acknowledge all the patients and families without whom I couldn't have had these results, and I won't be in front of you. Prof. Mehta and his team, MPS Society, who have been a major part of all our patient care, really. My colleagues at the Willink, and Alesh and his team, who helped me with all the studies we've done on the heart, and all the other colleagues who've been collaborating with us, including Rosella, who I've collaborated for nearly 10 years now. Thank you.